All right, I'm going to go ahead and welcome everyone to the weekly presentation of the UNM Law and Mental Health Seminar, sponsored by the Department of Psychiatry and Behavioral Sciences at the University of New Mexico. I'm Jeff Youngren. I'm the co-director of the postdoctoral fellowship in forensic psychology here at UNM, old friend to many of the people out there. Would best wishes to all of you. I'm happy to be doing this introduction. It's a real privilege to have Dr. Swanson with us for the presentation. Let me give you a brief introduction to Dr. Swanson. He's a professor in psychiatry and behavioral sciences at Duke University School of Medicine and a faculty affiliate of the Wilson Center for Science and Justice at Duke Law School. Dr. Swanson holds a Ph.D. in sociology from Yale University, Steve Menke School. He is also a social scientist researcher who collaborates across disciplines to build evidence for interventions, policies, and laws to improve outcomes for adults with serious mental illnesses in the community. Dr. Swanson and his colleagues have published significant research studies on the epidemiology of violent behavior in connection to psychiatric disorders, effectiveness of involuntary outpatient commitment, and the implementation of psychiatric advance directives. He received the 2020 Isaac Ray Award from the American Psychiatric Association and the American Academy of Psychiatry and Law for outstanding contributions to the psychiatric aspects of jurisprudence. He received the 2011 Carl Taubes Award from the American Public Health Association for outstanding contributions to mental health services research. Swanson served as a member of the John D. and Catherine MacArthur Foundation, well-known foundation in our country, for public health and law research program. He is also affiliated with the Wilson Center and has served as a consultant to policymakers at the state and national level. So Dr. Swanson, on behalf of the University of New Mexico and the Department of Behavioral Sciences and Psychiatry, we appreciate very much your taking the time to be a part of our program, and the talk is yours.
Thank you very much, Jeff. Jeff number two. I'm Jeff number one, I guess now. Good afternoon, everyone. I should say from North Carolina, good morning if you're on Mountain Time or elsewhere. It's a real privilege for me to join you today in your seminar, and I'm hoping we'll have some time for some conversation at the end. The topic of my talk today is involuntary outpatient commitment, sometimes known as mandated community treatment, or a bit more euphemistically, assisted outpatient treatment, or AOT, in the United States. And my subtitle, Effectiveness and Ethical Considerations. So we're going to talk about both those things. Just a little bit of background about outpatient commitment, its sort of legal authority and its historical context in the United States. So every state, as you well know, has some statutory authority to override someone's right to refuse treatment and detain that person in a healthcare facility for evaluation if they have a putative mental illness and pose some risk to themselves or others, and they need treatment to mitigate that risk. And that varies from state to state, but most states have that in terms of inpatient commitment, civil commitment authority. And what outpatient commitment does, it sort of extends that authority from the hospital setting, from the institutional setting, into community-based mental health care. So someone can be mandated to participate in treatment as an outpatient with mental illness. Where this came from sort of emerged in the latter part of the 20th century in the United States as a kind of a ripple effect of deinstitutionalization. After, in the 70s and 80s, so many of the mental hospitals reduced their beds or closed, with this hopeful idea that was inspired by sociological critiques of the asylum and the idea that people would do much better recovering from mental illnesses in the community and the improvements in pharmacotherapies, there was a great hope that a community care system would arise and would be appropriately funded to take care of people in the community. And that actually didn't happen that way, as you well know. A lot of reasons for it. In the 1980s, the community mental health centers were essentially defunded by legislation in the Reagan administration. And what emerged was a problem that was often referred to as the revolving door syndrome, where people who had been hospitalized with a serious and disabling illness such as schizophrenia, and now they're in the community, and for any one of a number of reasons, either they are unwilling or unable to participate in recommended treatment, so they stop taking that treatment, they deteriorate clinically to the point where they again meet inpatient commitment criteria, they come back to the hospital, they are discharged in a shorter admission, and then the same cycle happens again. And in some of our studies, we've had people with a history of dozens of psychiatric admissions. So this was an idea, let's try to interrupt that by using a legal tool derived from civil commitment to essentially wrap a court order around a treatment plan in the community with intensive services so that a person will participate in treatment, whether they want to or not, in the community. And this began, I'm pretty sure, as a form of conditional release from the hospital. So, it's a less restrictive alternative. Somebody's in the hospital and they can be discharged sort of conditionally and brought back if they don't do well, even without another commitment hearing, because they're essentially still sort of an inpatient. And the key elements of this are that it's a civil court order. It's not criminalizing in any way. It requires certain people with serious mental illnesses to comply with a plan of treatment in the outpatient setting, receive these services. Arguably and conceptually, it also commits the mental health care system to the patient and vice versa. So on the one hand, the patient should feel some leverage through a court order that they have to do this. And on the other hand, the care system should feel accountable to providing those intensive services to that individual. So as I mentioned, it's kind of a treatment plan wrapped in a legal order. And the legal order itself is kind of an empty vessel. So if someone is ordered to treatment and the treatment that is available is little or nothing, that's going to be very different than a treatment plan that includes a comprehensive set of services, such as an intensive case management program, or being on an assertive community treatment team, having a medication regimen with someone who helps the person comply to it, psychosocial treatment, and really importantly, access to subsidized housing. That's probably, if we get down to looking at the studies of where and how AOT works, access to housing so somebody can be stable and then actually benefit from treatment is probably really important. So the sanction for non-adherence, what happens if somebody doesn't follow the court? Well, this is not like a typical court order from a criminal court that if somebody doesn't comply with it, they have some real consequences and can be held in contempt or whatever. This is different. It's not meant to be criminalizing. So all that can really happen typically is that police can transport a person. There's a pickup order. This person isn't participating, didn't come to treatment, and to a mental health facility. They can be evaluated, hopefully persuaded to participate in treatment. But if they don't, and they don't meet involuntary hospitalization criteria, at that point, there's really nothing else that can be done, because with a couple of exceptions, there's no forced medication in an outpatient setting. That's typically something that's done with an order in a hospital. So there's essentially three types of outpatient commitment statutes in the United States. So you could call conditional release a form of outpatient commitment because somebody is in the community, they've been hospitalized on the tail end of a hospitalization, they're in the community. They call it a visit to discharge or a trial visit in North Carolina. And it's a little different because there's no separate order. It's just someone is discharged a little bit earlier, but they're essentially still a hospital patient and can be brought back. Then there is a form that 16 states have that is an alternative to hospitalization for people who already meet the commitment for an inpatient, involuntary inpatient admission. And for example, the person has been found to be dangerous to self or others and acutely mentally ill, and so they could be involuntarily committed, but instead, there's this idea that they could be sent to the community as a less restrictive alternative. Now, that, for reasons that might be a little bit obvious on the face of it, wasn't used or isn't used very often because, a risk-averse psychiatrist who has found the person to be dangerous is right now imminently in hospital and committable, is sometimes reluctant to approve an outpatient disposition, just concerns about what if something happens and then the doctor is held liable. And Paul Applebaum has made that point in print. So the third type is the most popular. It's also the most controversial, and we're going to get into that. Preventive outpatient commitment. 36 states in the DC and New Mexico's AOT statute looks like this. It's coordinated treatment that's authorized at a lower threshold than inpatient commitment. So the purpose is to prevent further deterioration. And what it means is that someone doesn't have to be imminently dangerous. They for reasons established by their clinical history, it can be determined or predicted that they are, without the supervision of a court, they're not going to participate in treatment. They're not going to be able or willing to comply with this. And the second prediction sort of nested in that is if they don't participate in treatment, they're going to deteriorate. And if they deteriorate clinically, they will become a danger to self or others in the future and meet commitment criteria. So it's sort of like you take that forecasted scenario and you import it back into the rationale for ordering someone into treatment. Now, for reasons we'll get into, it's controversial if you think about it from the perspective of a consumer with mental illness who is not imminently dangerous and not criminally accused and not incompetent. So then there are now 3 states that do not have outpatient commitment statutes: Maryland, Connecticut, and Massachusetts. And New Mexico used to be on that list for many years. It was on that list that the Treatment Advocacy Center would hold up and say, look at these 4 states that don't have AOT. So I'm going to give you an example of sort of the top line kinds of criteria in a preventive outpatient commitment statute using North Carolina as an example. And that is, the first is a presence of a serious mental illness. A diagnosis such as schizophrenia is a typical one people have who qualify for this. There's a capacity to survive in the community with available supports. A clinical history that indicates the person needs treatment to prevent them from deteriorating. That's what would happen without it, but for the treatment, they're going to become dangerous. And a mental status that limits or negates the person's ability to make informed decisions to seek or comply voluntarily with recommended treatment. So how that is established, I have a slide over here in another window I can't show you, but it's New Mexico's version of this statute, and it elaborates on this, how do you demonstrate a lack of compliance to treatment for a mental disorder? So in New Mexico, there's several ways. One is at least twice within the last 48 months, there's been a significant factor that noncompliance has been a significant factor in necessitating hospitalization or receipt of services in a forensic or other mental health unit or a jail or a prison or a detention center, provided that the 48-month period shall be extended by the length of any hospitalization. So basically you look back 48 months and you say, did somebody get hospitalized or did they at least twice, were they incarcerated? Did they receive forensic services? And the reason for that was noncompliance. You got to tie it to that. Then the second one is it resulted in one or more acts of serious violent behavior towards self or others, or threats or attempts. So there's this dangerousness criterion in the past. And then the third one is it resulted in the person being hospitalized, incarcerated, detained for 6 months or more. So there's these different ways that the history of noncompliance can be established. It has to be noncompliance that results in one of these things. And then there are several other criteria here. You have to be unwilling or unlikely to participate. That's similar to the North Carolina statute. In need of AOT, that's the need for treatment criterion to prevent that. And then there's one that's also a little bit controversial, which is likely to benefit from receiving assisted outpatient treatment. We can talk about that later. That's a little bit of a slippery one because not everybody does benefit, and you have to say the person's likely to benefit to meet this criterion formally. So let me just say something about the opposing perspectives on this and sort of the source of controversy. And, this really has, the outpatient commitment is really a fault line. It's almost kind of a civil war in the mental health stakeholder community, with people lining up on one side and the other. And it's become kind of a symbolic issue for how, where you stand on this issue of autonomy versus paternalism from an ethical point of view. So the psychiatric paternalism view, which emphasizes individual compliance and treatment access, is really associated mostly with the name of Dr. E. Fuller-Torrey, who founded the Treatment Advocacy Center. And Fuller-Torrey, this is just one quote, a mandatory treatment for those too ill to recognize they need help is far more humane than our present mandatory non-treatment. So, and Fuller-Torrey was often used the analogy of, well, we wouldn't allow our grandmother with Alzheimer's disease to wander around on the streets of a big city just because she didn't know that she had a major neurocognitive disorder. That would be inhumane. We wouldn't treat our grandmother that way. Why do we treat young adults with schizophrenia that way? It's inhumane and it's a scandal. And so therefore we need to use these legal tools. And he was actually in favor of rolling back civil commitment criteria to make it easier to commit people. You didn't have to be imminently dangerous. If the doctor thought that you needed treatment, that should be, enough. So then you have the civil rights perspective, which really advocated for system reform. And the idea there was, well, if the problem is that you can't engage people with serious mental illnesses in treatment, that's a service problem. That's not a legal problem. Outpatient commitment, this is Bob Bernstein, I believe, wrote this, who used to head the Bazelon Center. Outpatient commitment is not a quick fix that's going to overcome the inadequacies of an under-resourced and underperforming mental health system. Coercion, even with judicial sanction, is not a substitute for quality services. So that view really, it starts with a sort of if you think of the narrative at the individual level, think of someone with, say, bipolar disorder who's in the community, and that person says, well, I know I have bipolar disorder. I know more about this than anybody else in terms of how I experience it. I want to recover, but I want to do that on my own terms. And it's up to me. And we live in a society where we value the rights of individuals to make their own decisions about important things like healthcare, including being able to refuse healthcare if you don't want it. And so I'm not dangerous right now, and I'm not mentally incompetent, and I'm not criminally accused. So on what basis does the state say they're going to override my right to refuse treatment and give me this AOT order? Now, that's actually a very uncommon scenario in terms of how people get on AOT. Much more typically, it's a step down from being on involuntary hospitalization, where a person is able to get out earlier, and it's a less restrictive alternative than remaining in the hospital. So it's sort of like how you view this, sort of where you're standing. But it continues to be controversial. So the American Psychiatric Association has a position statement on this, which I'll just mention a couple things going by. They indicate that it can be useful, this is based on research, to promote recovery through a program of intensive outpatient services designed to improve treatment adherence, reduce relapse and rehospitalization, decrease the likelihood of dangerous behavior in a subpopulation. This is not for everybody. This is just for this small group of people who really have difficulty and need treatment. And if they don't, bad things are going to happen. That's the idea. They go on to say that the goal of involuntary outpatient commitment is to mobilize appropriate treatment resources. So it's kind of like committing the service system as well to make services available and to make them more effective and improve this person's adherence to a treatment plan. It should not be considered as a primary tool to prevent acts of violence. That's an interesting statement in the APA position statement, because that's actually how a lot of these AOT laws were enacted. There's no accident that Kendra's law in New York and Laura's law in California and Kevin's law in Michigan are all named after homicide victims where the perpetrator was found to have a mental illness. That's when people get concerned. That's where there's the opportunity for a state legislature to respond to public outrage and say, let's do something about mental health, as we have now, actually, in the aftermath of these horrible mass casualty shootings. And so AOT statutes they tend to be enacted at times like that. But as they're actually used, given that most people with serious mental illness, as the large majority, are not violent, that's not the big reason or the way in which it's used. Although I'm going to show you some research on that, the subgroup of people who might be at risk of violence. So it goes on to summarize some research that it can be effective. It's most effective when it includes. This is kind of what's inside that that vessel of the court order, when it includes a range of medication management, psychosocial services equivalent in intensity to those provided on an ACT team or an ICM case manager. And the states adopting AOT should assure that adequate resources are available to provide such intensive treatment to those under commitment. That's the key point. Commitment to nothing is going to have a predictable result. So this is a map that just shows you the number of states that have active AOT programs. This might be a little bit out of date. This comes from an article by Meldrum and Associates in 2016, where they did a survey to look at whether states not only had a statute, but had an active AOT program. And most of those, let me just go back a second, most of the states that have active programs have the form of the statute that I described as preventive outpatient commitment, similar to what New Mexico has. I should have mentioned, though, about New Mexico's AOT program. It's interesting that it is, and I'm quoting here, available only in jurisdictions that have opted in with a memorandum of understanding between the jurisdiction and the local district court. So it's not something that's automatically universally available, as I understand that provision. So how common is outpatient commitment? Well, from studies that we did with the MacArthur Research Network on managed community treatment, about 12 to 20% across 5 state samples of large samples of outpatients with serious mental illness in public behavioral healthcare systems reported that they had experienced outpatient commitment as it was described to them. So it's not a trivial proportion. And 44 to 59% across these sites reported that they had received some form of what we referred to in the network as leveraged outpatient treatment. So that could be something like a condition of probation or parole that someone has to participate in treatment, or a social welfare form of leveraging, such as if someone has a representative payee for their SSI benefits and they're required to participate in treatment, or they won't get their spending money, or they have a subsidized housing arrangement where the landlord says, as a condition of this lease, you have to go to treatment and take your medicine or you can't live here. Those kinds of contingencies. And actually, just in passing, the last two I mentioned, the kind of social welfare leveraging, those are perceived by many consumers as being more coercive than an outpatient commitment order. So here's the big question, isn't it? How does outpatient commitment work? And the answer, of course, if you're an academic who studies this, is it depends. It's interesting. You like to have an expert take a complicated subject and make it very simple. And I guess I'm the opposite kind of expert. Take something that sounds like it should be simple and make it complicated. But it is complicated because, does outpatient commitment work invites a number of other questions. What do we mean by outpatient commitment? I've already, mentioned there are different types of it. And what do we mean by work? What's the goal of this? Are we talking about just improving outcomes that systems of care really care about, like saving money? Do we do we want to know if it works in the view of and in the perception and the subjective experience of people who actually receive this in ways that are meaningful to them? Those might be two different things. Does it work compared to what? I mean, compared to the same person if they didn't have this as a counterfactual, or compared to people who receive voluntary care, or the same people before and after? People in other jurisdictions don't have outpatient treatment. And does it work for whom? I mean, it might not work for everybody. Maybe there's sort of a therapeutic window where certain people will benefit from this and others will not, maybe even, would react adversely to it. Does it work where? Just because it works in New York City, does that mean it's going to work in rural New Mexico or in London, where the system of care might be different, the populations might be different? And does it work how and for how long? Does this work by essentially changing the compliance behavior of a patient, or does it work by changing the behavior of a system of care in making assisted outpatient treatment services like an ACT team or an intensive case manager available to someone? And how long does it have to last? You could think of, is this kind of like if you break your leg, you need cast on for a while, and after your leg heals, then you don't need that. So this is a way to sort of temporarily engage people back into the service system where they will participate voluntarily. Or is it something that's more like a crutch, or something that someone will need forever because they'll never be able to get along without this court order? They'll fall out of treatment. And then does it work? Well, so what? Should we do it? That's a different question. There are lots of things that actually work, have some efficacy, that we shouldn't do because maybe they have side effects that are, or maybe they're just too coercive or too expensive or what have you. So the normative question is a little different than all of this. So these are some questions that, we continue as researchers to try to answer, and policymakers do as well. So just very quickly mention a couple of the, top line findings from studies that have been done. There are three well-known randomized trials of outpatient treatment. We did the first one at Duke back in the late 90s. My colleague Marvin Swartz convinced the district court judges to allow us to randomly assign people coming out of the hospital who already had been ordered to outpatient commitment. Flip the coin, and if you get heads, you stay on AOT. If you get tails, essentially that order is vacated and you go out of the hospital with a voluntary case manager, but you're under no obligation. There's no court order. And we followed up those individuals for a year and looked at outcomes, including hospitalization and clinical outcomes and other things. Then there was a study in New York City at Bellevue Hospital, Hank Stedman and colleagues, and we were involved in the background with that one. That was a brand new program. It was a small study. There were problems with it being ramped up and who was in which group and so on. And it basically had null findings, but was subject to some critique on its methods. And then there was a study in the about 2014 was published, the papers from this, the Octet study in London by Tom Burns at Oxford and his colleagues. And Dr. Burns attempted to replicate the North Carolina study in the UK. I'm not sure the design quite succeeded because the equivalent of the IRB there would not authorize a study or allow it to have a random assignment to voluntary versus involuntary care. So what they ended up studying was community treatment orders compared to people who were on a form of a conditional release that didn't last as long. And that study found no benefit, according to the way Dr. Burns reported it in his papers. Again, one could argue about the methods and the comparability. So then the largest actually study in the United States was the New York AOT study funded by MacArthur and the New York Office of Mental Health. And what that did was it used a large number of participants in a quasi-experimental framework using Medicaid claims and all kinds of other outcomes where we could statistically model outcomes rather than have a randomized comparison group. There have been several evidence reviews, a RAND study, a UK report by Rachel Churchill and others, and a Cochrane collaborative by Steve Keisley, who's a kind of a robust critic of AOT. And then, the US experience, there's a book chapter edited by Alec Buchanan and his colleagues that we've written a couple of chapters in that book. So what does all this come down to? And there's international evidence. It varies a little bit. Big picture summary is that the effectiveness evidence for this is mixed, but success is conditioned. When it works, it's conditioned on there being an appropriate investment in effective implementation. In New York's program, there was a $100 million appropriation that really boosted the capacity of the system to provide team slots and intensive case management and so on. There has to be the availability of intensive community-based services. Also, the duration of the court order. In our study, really, if a person just came out of the hospital and their order expired because it was a split commitment and it expired within a couple of weeks, and they didn't really get much outpatient treatment, there's no reason to expect it would have a lot of benefit. And in fact, that's true. So we had all these variable lengths of outpatient commitment, and where it really worked very well were for people who had at least 6 months of AOT combined with intensive services. Now, of course, our critics then said, well, we lost control of our randomized experiment because we couldn't actually randomize how long the AOT order lasted. And how do we know we didn't capitalize on people who were just doing very well? They got the court orders. So we tried to address that question and looked at baseline risk of non-compliance and so on. And we think it's the opposite, that the people who were not doing as well were more likely to have the order extended, whereas the people who were doing well, it's more likely that they didn't meet the criteria anymore. But that's a methodological debate, and how you view our study tends to line up with how you view AOT. So the service system utilization outcomes versus individual perspectives and perceptions. So that's another one. If you really want to have the whole question of AOT rise and fall on whether people like it and will tell you thank you afterwards, you're probably not going to get there. But we'll look at some data on that in a minute. So here's just one example from some of the papers that came out from the New York study. This is published in the American Journal of Psychiatry and back in 2013. These bar graphs represent a cost. You can see over there on the vertical axis per person, and they're by category. And I've circled the outpatient mental health treatment bars right there. The red bar is the 12-month period before discharge to AOT. So that's how much money per person was being spent on services, in the Medicaid program in the New York system there for outpatients for these people with serious mental illnesses. During the year of that they were on AOT, that tripled to about 15,000. And then the year afterwards, it didn't go back down to where it was. It stayed pretty high, $12,549 per person being spent. This is back before 2013. But now look at this slide. Let's look at the inpatient treatment pattern. So the inpatient treatment pattern is pretty spectacular. In the year before, let's look at hospitalizations in New York State Office of Mental Health. Those are OMH hospitals. During the 12 months before that person went AOT, the state was spending $49,000 per person on average on hospitalization. That went way down to just around 12,000, just south of 12,000 during the year on AOT. It bounced up just a little bit in the year afterwards to 14,000 approximately. And about the same pattern there you can see for Medicaid hospitalizations. So you put those two things together. I know there's not a direct cost offset. You don't take money directly out of hospital admissions and put it into outpatient care, but there's the potential for savings there if you just look at this logically, I think. So what about this question of should we do this and is this ethical? So if you think about it as a bioethicist would, you might apply sort of this principlist perspective. You'd think about, well, what about non-maleficence? I mean, does it cause harm? And are the harms that people suffer outweighed by the harms that we stave off or that we prevent? beneficence. Are we doing good for people? And are we respecting people's autonomy and their own right to make decisions about healthcare, including the right to refuse it? And justice. Are outpatient commitment programs fair? They fairly distribute benefits, burdens, and risks. And these are principles you probably learned in some form from your grandparents. And of course, if we're talking about my grandparents, there's also the question of does it spend too much money? Because that's what they were concerned about as well. And that's a question that we can think about too. So we've done some research on this, and for example, a study of what do AOT recipients themselves think of it after they've had it. So subjective quality of life, endorsement of personal benefit, that's sort of the thank you theory applied to outpatient commitment. Formal preference assessments, kind of like an economist would establish a utility for some outcome, and perceived fairness and perceived coercion. I'll give you a couple of examples. So this study, these bar graphs represent the percentage of patients who had AOT in North Carolina. There's the total sample, and we first just asked, well, do you think this was a good thing that benefited you, that should have been done for you? And if you ask patients that way, they've had it. 27% say yes. That's the level of retrospective endorsement of this. So we thought, well, that's not very good. Let's stratify and let's look at people who objectively had a positive outcome. They stayed out of the hospital. They weren't arrested. They have a good, global assessment of functioning score at the end of the year. And let's compare them to people who had negative outcomes, like they did get hospitalized, notwithstanding AOT. And there you see a split, but it only goes up to 45%, even among the people who had positive outcomes. So if we're relying on people's retrospective, thank you, yes, you should have done this to me, we're probably going to come up a little bit short. We need other ways of justifying this policy. So this paper looked at the direct and indirect effects of AOT on subjective quality of life. So we measured subjective quality of life at 12 months and looked at the, regressed in a regression equation, quality of life on days that you had on outpatient commitment. And you see there's a positive effect there. There's statistically significant. The more days of AOT you had, the higher your subjective quality of life at 12 months. And then there's a mediating effect. So you put two other variables in the equation: increased use of mental health services, decreased symptoms of serious mental illness like psychosis and dysregulated mood or what have you. And there you see that there's a positive indirect effect, and the direct pathway from AOT to subjective quality of life is not significant anymore. So that would make sense. That's good news. But just to complicate it a little bit further, there's also an indirect pathway that's negative. So the more days on AOT, the more people perceived coercion, and that's a bad thing. So, that increased their sense of being coerced. And the more coerced people felt, the lower their subjective quality of life. So, this looks like a paradox, like, well, is it good or bad? Well, it's kind of both. And so I think the analogy would be some kind of a treatment that has a benefit, but a side effect at the same time. So then the question is, you trade that off. Is the benefit worth the side effect? And one way of doing that statistically is you look at the effect size, and you see there's a bigger effect size on the positive pathway than there is on the negative pathway in terms of the beta in those regression equations. Another study we did looked to sort of the formal preference weights with Martha Shumway and others. And there, we found that, just to cut to the chase here, that some bad things and good things are more salient. So there was an importance weight attached to avoiding hospitalization. It's 1.9 on this utility scale, way more important than avoiding AOT. It was a smaller sort of tincture of coercion that people were bothered by with AOT, rather than avoiding hospitalization. And then there is a sort of a question about racial justice. And we published our results in New York. Of the New York study, there was a paper, and it got covered in the New York Times, a report by the New York Lawyers for the Public Interest, who, they titled their report, AOT is racist or something like that, because what they did is looked at the proportion of people who had AOT by a racial group, and then they compared that to the population in New York. and found that people were way more likely to get AOT if they were Black than if they were white patients. I'll show you the results of that and our response to it. Then there's a sort of a queue jumping question. Well, is it fair if there's only so many intensive services to go around and people are figuratively standing in line, and here comes this person with a court order and they go to the head of the queue to get things that might include a subsidized housing slot? Is that fair? And how do we think about that? So on this first one, I mentioned, so the over on the horizontal axis the vertical axis, that's the ratio of AOT for Black versus white patients in New York. And you can see that if you just compare the county population, that's the denominator, 7-to-1 Black to white patients getting on AOT. If you then use a different denominator, like the county population with serious mental illnesses, or the county population receiving public sector services, or the county SMI population of people who've been hospitalized, and all the way down to the denominator is, people who have been involuntarily hospitalized, there's a sorting process because of these upstream factors that for reasons having to do with the correlation historically between poverty and race, and social determinants of serious mental illnesses and so on, and treatment access, that by the time you get down to where the decision maker at the level of a district court is saying, well, yes, I'm going to approve this person for outpatient commitment, they could have a blindfold on and you'd still get a racially disparate result. Now, the two ways of looking at this, you could criticize our paper and say, well, you're just trying to let decision makers off the hook. You're just saying, well, it's this abstract thing called systemic, racial discrimination upstream, and it's not the people, it's the system. On the other hand, maybe we do need to look at how the system works, and try to hold people accountable at every level. But the big message here is how you think about disparity is directly related to how you think about the outcome. If you think AOT is about access to treatment, then you want people to have it who need treatment and who have been shut out from treatment in the past. If you think outpatient commitment is not about access to treatment, it's about coercion, then you don't like this, because then you're piling on this court order to a group of people who historically have received discrimination and oppression and so on. So I think that's important as well. So finally, this crowd out question, I call this the Neapolitan ice cream slide. What you see here on the vertical axis is the number of persons with Medicaid claims for assertive community treatment or intensive case management after AOT was implemented in New York. And there's four groups. Those who've completed an order, those who are currently under AOT, those who will have an order in the future, because we knew that. We looked across and then analyzed this retrospectively. And then the pink one is never received an AOT order. So what you see, if you stop this evaluation after 3 years, what you would conclude is that all of these new services for AOT, for being on ACT teams or intensive case management, they really went to those groups at the top, the people who were on orders or currently would have one or have completed one. And these poor people down there at the bottom were not, there was no increase in that group at all. But what happened is the whole system kind of equilibrated. And you see after that sort of inflection point that the number of people getting these services in the big pink plume at the bottom, that also goes up. Those people never qualified for AOT, and they still got it because the system was left with more capacity to provide those services as people graduated from AOT and so on. So, winding up here, Larry Fitch and I, he's an attorney, a mental health law expert and an academic, were responsible for drafting a report for SAMHSA on civil commitment, both inpatient and outpatient. And I will give you the link if you would like to read that report. But we tried to synthesize some policy guidelines for all commitments, and those are there. You can see them. The purpose must be treatment. Need for treatment is an essential ingredient. No commitment, inpatient or out, without reliable diagnosis. This is for people with serious mental illness. And no commitment solely for preventive detention or community control. That's not what this is for. No commitment if the person's willing or able to engage with services voluntarily. If people can want to do this on their own, there's no reason to use AOT. And the treatment staff should have the authority to, or should be able to terminate it when the person no longer meets commitment criteria. This is not something that should be kept in place indefinitely without the need. So, again, no outpatient commitment unless the person meets the inpatient commitment standard, but may be served in a less restrictive setting, or that's for the ones that have that type of statute. Without the services proposed, it's predictable that the person will experience further disability deterioration to the degree where in the foreseeable future, they're going to meet inpatient commitment standards. Now, whether we have the science to actually implement that is another question, but that's how it's supposed to work logically and legally. An outpatient commitment under number 2 may require an additional finding of impairment in the person's understanding of the nature of their mental illness and the treatment proposed, including the risks and benefits of treatment and the expectable consequences if commitment is or is not ordered. So I think I'm going to wind up there and try to leave a little time for you to ask some questions. This is a copy. You can see a screenshot of our report to SAMHSA, and there is the website for it. So I've been happy to share these remarks, and I'm looking forward to hearing any response or questions that you might have. Thanks very much again for the invitation.
Thank you, Jeff. Greatly appreciate very interesting talk too. I want to remind our viewers that if they have a question for Dr. Swanson, please enter that question in the Q&A box on the bottom of your Zoom screen, and we'll get those addressed. We actually don't have a lot of questions right now, so you seem to have covered everything perfectly. That's the way it looks. Well, let me read what I do have here.
Sure.
And again, the people attending, just enter your questions in the Q&A box on the bottom. So if a person does not comply with treatment, but doesn't meet civil commitment criteria, then what? They are not immediately brought back to the hospital as a violation, as would be the case if there was an NGRI order, Kroll order in New Jersey. I would think that it would be the first step in identifying potential decompensation early and preventing future problems, including future violence. Your thoughts?
Oh, they're
Jeff?
very good. Yes, very good question. So the way I would think about that is imagine somebody who is on an assertive community treatment team, the way they're supposed to work, the way they were designed, and meeting the fidelity for assertive community treatment. So that person, let's think about the person without AOT who is on that team. And what if they say they don't want treatment? They don't want to participate in treatment. Well, the case manager doesn't just shrug and say, well, okay, good luck. No, what they do is they are skilled in trying to overcome that person's barriers and, go to their house if they have to. And they, essentially try to build some scaffolding around that person to mitigate what might be an illness-related inability to understand their need for treatment or their ability to do it. So, and there is an argument that if we really had something like AOT on demand for everybody who needed it, we wouldn't need a court order. Come the perfect system of care, coercion is a symptom of bad care, and that's that view. So that's the sort of counterfactual I think that would take place. And what we do have is some examples, anecdotally and otherwise, of what happens when people do that. And it is difficult because there's kind of a lot of daylight between the pretty strict requirements for involuntary civil commitment to a hospital and sort of need for some treatment over here. I mean, there are a lot of people who need treatment and are going to fall short of what the state could actually do over their objection. But in the middle there are these models where there's intensive case management that attempts to overcome that and essentially find out what the barriers are and try to overcome those as well. So you reduce that to a clinical problem, I think. That's one way of looking at it. And in the end, if people are adamant that they don't want treatment, I'll just, let me stop, see if there's another question. If there's not, I'm going to share a very interesting anecdote with you that I think might be of interest. But I want to make sure.
We do have a number of questions.
Sure.
Too.
Yeah, let's go. Yeah.
So, I'm going to ask an anonymous question. We tend not to do this, but I think it's a very good question. This is from a social worker in a state psychiatric hospital. In my experience, many providers will not honor the outpatient commitment. Even if providers agree to help with commitment, it's somewhat of just something on paper, period. How do you get the outpatient commitment honored, or your thoughts about how one would do that?
Yeah, well, this is a that's the question, isn't it? And it's part of the whole dilemma of how you translate a good idea that's a legal tool into actually benefiting the people it's designed to benefit. You can call it the implementation gap. You can call it any number of things. But I think that's a hard one. It's often easier to pass a law than it is to actually get it implemented and get it out there and used and honored. Same problem a fortiori with psychiatric advance directives. So that's similar. All these states now have psychiatric advance directive statutes, and they're often not honored and they're not used. So I think that's a matter of educating providers, and I don't know actually what kind of legal leverage there is, because the way the orders typically are written is they are written for a person, not a system. There's no order given to the system or the provider. You, Dr. Smith or whatever, you must take care of this person and do X, Y, and Z, or you're in violation of a court order. That's not how it works. The order is on the person. So this is kind of a flaw. And, actually, AOT is widely criticized for not having any teeth. And I think it's all in how it's implemented. It can work, but otherwise, if you're going to rely simply on the legal sanction, you're right, it's going to come up short. But figure out how to bring these providers along, and if it works, they're going to build experience with it.
Another really interesting question we've got here, doesn't spin off of what you just answered, Jeff, but it's a question. Community homelessness associated with substance abuse and mental illness, does this mean AOT is not working in the communities or it's underfunded? I understand the tiny homes, N40, are filled at 13% rate. Implication is it's not working. Your thoughts?
Yeah, I don't think, yes, you could say it's not working, but what's the it that's not working? So the backstory here is we have a huge problem with lack of low-income housing. So trying to implement an AOT program where we just don't have enough places for people to live who have psychiatric disabilities or who just don't have a roof over their head is a challenge. And if you have a statute, like some states do, that you cannot put someone on an AOT order, or you can't let them out of the hospital on an order until you have a housing slot lined up, that's a real barrier to being able to implement it. So I agree there's a problem there. Question is it a problem, a larger problem with the crisis in low-income housing? Or is this something that we can blame on? And homelessness, why do we have this? I mean, it's not what's the one thing you should do? It's not a one thing problem. There's no one thing solution. There are a lot of things that have to do with upstream social determinants, has to do with, income inequality and all kinds of things. And, so it's kind of hard to figure out, well, what's in our lane or what's in your lane as mental health providers to figure out what you can do and what you do about the rest of it.
Okay, thank you. Another question. Washington State recently enacted the mental health sentencing alternative under which a qualifying defendant can go to community treatment instead of prison. Qualifying is a pretty low bar. One, having a serious mental illness, which Washington statutes and administrative codes don't define, and two, not surprising, would benefit from the treatment. So far, there's no case law offering additional guidance. The law strikes me as over-inclusive and offering little guidance for evaluators. What are your thoughts, Jeff?
Well, I think it's not hard to understand why that the questioner would see it that way. I think one thing I'm going to say about that is there has been a shift in sort of how people think about AOT as a model simply appropriate for people who are not involved with the criminal legal system. Their problem is just they're having poor outcomes in the community, and the revolving door is revolving hospital admissions. But there's a variation on that, particularly now where we have more adults with serious disabling mental illnesses who are in one of our huge city jails than we ever had in a large asylum in the middle of the 20th century, which is a big scandal. So now you have all of and they're not there because they're violent. Typically, maybe 10% are for a violent crime, but most of them are there for minor crimes that tend to be the kinds of things that somebody with a really serious psychiatric disability, they're just going to run afoul of the law in the community because they're not being taken care of. And so we've had a whole history of criminal diversion, jail diversion programs, pre and post booking, and mental health courts and things like that. AOT has been kind of on the side of that because it's really been focused conceptually on people who are not involved with the criminal system. Now, there's been, I think, a shift in thinking about, well, what about that as being a disposition for people who are reentering the community or who are accused of a crime? Maybe that's a way maybe that can interface with this problem we have with all these people who have been found incompetent or that are awaiting a competency restoration for maybe minor crimes. And how do we divert that group and get them into the community? There's an interesting debate there about, the clinicians might see it one way. Their interest is in getting people into treatment. And then you have the, civil rights minded lawyers who say, well, wait a minute, this person has rights, under the Constitution in terms of their criminal offense and so on. So, I know a little bit about the Washington reforms. I don't know enough to comment super specifically. I do know there's this interesting debate about whether the criteria for diversion should be not only that person has a serious mental illness, but that the mental illness needs to be deemed to be the reason that they committed the crime of which they're accused. So if you could just say anybody who's criminally accused, any defendant, if they have a mental illness, they qualify for diversion, that's going to be much broader. And there are people who really advocate for that because they say to make that kind of connect the dots between your crime and mental illness, that's really going to be a much smaller group of people. And, I can see arguments for expanding it.
Thank you. It's a timely question. You may want to sidestep it. I don't want to wander in the politics of this, but do states typically allow MOT plans to preclude a person from owning or possessing firearms? Have there been court cases on the potential limitations of Second Amendment rights with this? Are you familiar?
Yeah, that's a great question.
It is a question.
Yeah. Well, and I'll answer it by taking you back to 2007 to the Virginia Tech shooting. And if you recall, the perpetrator of that horrible massacre with firearms that he had purchased legally, when they started to look at his situation, it became apparent pretty quickly that he had been involved with mental health services in the state of Virginia. And in fact, he had been found to be dangerous to others and mentally ill, and had been ordered to undergo outpatient treatment at the community service board, and it slipped through the cracks. A, the person, he never got to treatment, and B, that record was not reported to the National Institute of Criminal Background Check Systems, which would have prevented him, he would have failed a background check. So Virginia responded by reforming that law, so that now was a disqualifier. And if you actually parse the language in the 1968 Gun Control Act, put that together with the Heller decision, it's pretty clear that outpatient commitment, particularly the preventive outpatient commitment statutes, as well as the others if people qualify for inpatient commitment, should be gun prohibitory. And they were made gun prohibitory by way of an executive order under President Obama. So now, under federal law, outpatient commitment orders should be reported to the National Instant Check System so that they would prohibit someone from purchasing or possessing a firearm, just the same as involuntary inpatient commitment. Now, as to whether states actually are reporting those records, that's a different matter. And a background check is only as good as the records in it and the criteria that prohibit people, which are too broad and too narrow at the same time. That's a different lecture.
Yeah, great answer. Thank you. To remind everyone that we've reached the top of the hour. Yeah, the link to receive the CEs has been posted by Alex. You should, those of you who want to drop off at this point are welcome to do so. I'm going to try and deal with the last few questions, Jeff, if that's okay with you. And
sure,
we'll run over a little bit because when I said I want more questions, God provided them. So here we are. Well, actually, the listeners provided them. So there you go. Anyway, my friend Ken wrote a question, which I think is very interesting. What are the confidentiality issues for a treatment team involved with involuntary outpatient commitment?
Yeah, so I would think I'd be interested in knowing what Ken's view is on that, because I mean the easy answer is that insofar as a treatment team is providing treatment to a person in the context of a mental health provider in the community, that provider presumably is a covered entity, and an AOT program doesn't exempt anybody from HIPAA requirements. So yes, the person's private health information, if that's the question, should be provided. Now, if the question is, can somebody's medical record be obtained by a third party for the purpose of just bringing somebody in for evaluation and sort of putatively saying, hey, well, this person looks like they need an AOT order, so let's get their medical records for the purpose of getting them on AOT and bringing those to the court. That's a little stickier issue. And I believe that was litigated in New York. And I think the decision that I'm speaking off the cuff, but I think they did allow that basically under the idea that this person, needed treatment and was putatively dangerous. Some, like you would have exceptions to the Fourth Amendment's requirement of getting a warrant if someone, like let's say someone's calling for help in a house and then the police knock on the door and they don't answer. The police don't need a warrant to go in there. There are exceptions to the community caretaker exception. This is sort of analogous to that, I think, a little bit, is that there's exigent circumstances that require this information. But there's an argument to be made. That person hasn't been put on AOT, and how are you going to get my private records? I'd be interested. There are probably people on the call that know more about that than I do. It's an interesting question.
Being a person who knows a smidgen about it, I think that HIPAA does allow the exchange of protected health information for treatment. It's the state laws that modify it. So somebody in a clinic or as a part of a treatment team would be able to have access to the information related to the treatment of that individual. Anyway, let me, okay. Your thoughts about first conducting a cost benefit analysis, i.e. what do you get, what do I get, what I don't like for treatment versus what I get, what I like with respect to helping a client make a decision about voluntary treatment versus involuntary outpatient treatment. Does that make sense? Or
Well, could you rephrase that for me? I'm having a little trouble getting my head around it.
I'm going to read it verbatim and if we can't do it, we can't do it. Your thoughts about first conducting a cost benefit analysis. What do I get that I don't like for treatment versus what do I get that I do like with respect to helping a client make a decision about voluntary treatment versus involuntary outpatient treatment?
Yeah, so the most interesting thing about that question is the premise that a patient would have the choice, would be presented with a choice, and one choice would be involuntary treatment. That invites the question of what does voluntariness mean if someone is being given a choice between a voluntary or an involuntary regime. The analogy that springs to mind is a Ulysses contract where someone says, you know, I might have a mental health crisis in the future, and that to protect myself from what I might do or what the ill person who looks like me will do is I want to authorize treatment over my own objection in the future if I get into a crisis. And so choosing involuntary treatment in advance at that portal is kind of like that. The person would have to be competent. They'd have to say, you know, I know that I might, you know, stop taking my medicine and I might not go to appointments. And so to prevent me from doing that, if I become ill, I'd like to actually have an outpatient commitment order. I mean, it's kind of hard to imagine that scenario exactly, but I guess you could do it that way. The idea of weighing risks and benefits of this, that's another interesting one because there's the risks and benefits involved with the court order, right? Okay, well, what if I don't follow it and the police come and pick me up, you know, with all the trappings of a criminal arrest and take me in a cruiser and with, you know, handcuffs on, versus the risks and benefits of the treatment that's in there. So what if a person on an outpatient commitment order gets assigned to a different antipsychotic medication, you know, one that might have a different risk profile for metabolic syndrome or something like that. And so that's treatment that's inside this court order. And if part of the treatment plan is what they're supposed to follow. There are ways of trying to combine voluntariness and you know, a mandated treatment regime. New York actually says that if a person has a proxy decision maker and a mental health advance directive of some kind, that's supposed to be included and considered when developing the treatment plan. I haven't been able to find any examples of when that's actually done, but somebody thought that would be a good idea.
Okay, one last question, Jeff, which I think is really asking for a resource from you, but I think also some content here. I'm often asked in New Jersey courts if a defendant with untreated mental illness could benefit from outpatient commitment. And when I agree, most judges have no idea how to order this type of treatment. Is there a website with this information available, or do you have a reference that they can use to address it?
Yeah, I think that's going to be a state-specific question because the resources for it, I mean, the obvious resource to find out as much as you want to find out about outpatient commitment would be the Treatment Advocacy Center. They have, you know, gathered state-specific information on AOT and, you know, have been advocating it and trying to get it implemented and for, you know, decades. And so that's what springs to mind. But I actually know some clinicians in New Jersey that I would ask if I wanted to know that myself. So I'd be happy to do that. Another resource just in general about this is the SAMHSA report that I put up in the last slide. I think that's got some good information in it as well. But yeah, to initiate the petition, a clinician can do that. Typically, a psychiatrist can initiate the petition, and there's paperwork to do that. There's a form to do it.
All right. Well, I really thank you for a stimulating and informative talk, Jeff. We're proud to have you be a part of our program, especially considering the high level of compensation that our speakers get,
Yeah.
which is zero.
Yeah. Thank you. Yeah.
It's really a community involvement, and the University of New Mexico greatly appreciates it. And thank you for your time. I think next week, and Alex, correct me if I'm wrong, isn't Park Dietz talking next week?
Yes, that is correct. Next week.
So we invite everyone to come and watch Park talk about his experience in forensics. And Jeff, on behalf of the University of New Mexico, super thank you for a great talk.
Thank you for inviting me, and I'm glad to be the warm-up talk for the warm-up act for Park Dietz. So,
if that's possible, right?
Okay. Yeah, right. Yeah, I don't know. He may wear a tie. I think I'm probably the only person on this call who wore a tie, but that's all right.
No, on occasion people wear ties, but we usually require them to wear UNM ties. And you don't have one of those, and you couldn't wear it at Duke anyway, probably, right?
Yeah.
All right.
Well,
So
yeah. Okay. Thank you. You bet.
Thank you very much.
Thank you.